Assessing Sensory Function and Pain. This program is offered by the Beacon Institute through a special grant from the Office of Healthcare Quality. This program should enable you to identify and discuss age-related changes affecting sensory input, describe the basic process for assessing sensory function, identify pain-related conditions experienced by older adults, describe the process of assessing pain, and identify common nursing diagnoses and care plan considerations related to sensory function and pain. We will begin the review of sensory function with a discussion of vision. The eye undergoes some changes with age. Overall visual acuity decreases. Presbyopia, difficulty with near vision, develops, making it difficult to read, see food items on a tray, identify hygiene products, etc. Older people need more light and more of a direct lighting source to see things, although bright, harsh lighting is not advised as it can produce glare to which older eyes are more sensitive. They will have a harder time accommodating to light changes, either light to dark or vice versa. Muscles that regulate the size of the pupil weaken with age, causing problems with changes in light. And there is a yellowing of the lens, causing problems distinguishing blues, greens, and violets. Depth perception depends upon perceptions of color, contrast, and lighting. Since all of those things may be compromised, then depth perception may be impaired as well. Shadows may be interpreted as separate objects. Eyes become drier due to less tear production. The cornea is less sensitive, which can cause early signs of infection to be missed. Floaters, or spots floating across the visual field, appear. Additional age-related changes can include ptosis, a drooping of the eyelid, which can compromise the visual field, a turning out or ectropion of the lid, which contributes to eye dryness, excessive tearing, and irritation, a turning in or entropion lid, where the eyelashes and skin can rub against the eye, causing irritation. It can lead to corneal abrasions, ulcers, and eye infections. There are some eye conditions that are common with age, such as diabetic retinopathy, in which damaged small blood vessels in the eye cause a leakage that impairs vision, and cataracts, which are a clouding of the lens, causing vision to be blurred, increasing sensitivity to glare, and problems with night vision. Macular degeneration causes an impairment of central vision. Be aware that when talking to someone with macular degeneration, they may have the tendency to turn away from you. They're not being rude or not paying attention. They are trying to see you in the periphery, since if they look straight at you, they won't see your face. The visual field deficit in glaucoma is just the opposite. Glaucoma involves a progressive loss of peripheral vision. Individuals affected by glaucoma have trouble seeing to their side. For example, they may not see the water that's left on the bedside table and not consume adequate fluids as a result. Hemianopia is blindness over half of the visual field and is usually associated with either stroke, brain tumor, or trauma. Homonymous is blindness in the same side of the field in both eyes. Bitemporal refers to blindness that affects the outer half of the field in both eyes. Opposite that is binasal, which affects the inner half of the field. Superior and inferior hemianopia refers to blindness of the upper and lower half of vision, respectively. When assessing the eye, note the condition of the eyelids, discoloration, tearing, lesions, unequal pupils, and lack of pupil response to light. Some unusual findings could include conjunctivitis, associated with an inflammation of the conjunctiva, Scholosian cysts, which is a lump in the eyelid, either the upper or lower, caused by obstruction of the drainage duct of an oil gland in the lid. It can become inflamed. It's often confused with a stye. A stye is usually on the outer edge of the lid and involves inflammation of the follicle of the eyelash. Blepharotitis is an inflammation of the eyelid, often causes clumping and stickiness around the lashes. Look for PERRLA, standing for pupils equally round and responsive to light and accommodation. Check the pupil response to light. Ask the resident to look straight ahead. Note the appearance of the pupil. Then slowly bring the light of a flashlight from the side of the head and note the pupil reaction. Repeat for the other side. The pupil should constrict. There are 6 muscles that work together to control eye position and movements. These muscles are controlled by 3 cranial nerves. It's important that the eyes move together so that the image to the eye falls on the same place on the retina of both eyes. Double vision, diplopia, can result if eye movements aren't coordinated. To assess eye movements, have the person look straight ahead, then to the left and the right. Look up, and then to the left and right. Then look down and then to the left and right. And then to look at your finger placed near the end of the nose. It is important to know if the resident wears eyeglasses or contact lenses. If so, explore when they last had an eye appointment. Eye exams should be done at least annually, so if it's been more than 1 year, it would be important to schedule an appointment. Surveyors have been known to cite facilities for giving medications without appropriate monitoring if those using glaucoma meds went more than 1 year without an ophthalmologic exam. Make sure to do a careful reconciliation of meds upon a resident's return from a hospitalization, as glaucoma meds often fall off of the medication orders when transferred back from the hospital. An interruption in glaucoma meds can potentially harm residents due to the increasing ocular pressure. Ask about sensitivity to glare, problems with adaptation to changes in light, problems with night vision, flashes of light, halos or rainbows around lights, blind areas, spots or floaters in the visual field, haziness or cloudiness to the vision, problems seeing with the current prescription for the eyeglasses or contact lenses, near or distance vision not as clear, accidents bumping into things or tripping. Glare, rainbows, or halos around lights are all caused by how light enters the eye. Flashes of light can indicate a number of problems, including digitoxicity and retinal detachment. Peripheral vision is your side vision, things in your visual field outside of your focus area. Loss of peripheral vision is a sign of a number of eye diseases, including glaucoma and optic nerve disorders, so it should be tested regularly. It's easy to do and doesn't take that long, but can give you useful information. Awareness of a resident's loss of peripheral vision is important for safety concerns, as well as approaches for resident care, as we should avoid approaching that person from the affected side. To test for peripheral vision, seat yourself opposite the resident about 1 or 2 feet away. Have the resident cover one eye, and you cover your own opposite eye. Tell the resident to focus the exposed eye on your eye that is opposite. Extend your hand to the side and wiggle your fingers. Gradually move in from the side while the resident and you look straight ahead. The resident should see your fingers about the same time that you do. Repeat this with the other eye. Use a newspaper to help to get an idea of vision. It's helpful as it has different sizes of print so you can determine what size they can easily see. To assess general visual field, have the resident look at something across the room or the hallway and tell you what can be seen clearly. It's especially important to know what size print they can read for safety reasons, such as labels for personal care products and medication instructions. Assure that eyeglasses or contact lenses that the resident uses are worn during this exam. Consider some of the examples of approaches to use in the resident care plan for compensation of visual impairments. The use of contrast is particularly important. Consider if you had blurred or hazy vision, how difficult it would be to sit down at a table to dine when everything looks the same. Use placemats and contrasting colored plates to make them appear easier to identify. Use of a contrasting color on steps is a safety feature. Otherwise, the person may not be able to distinguish the edges of the step. Bathrooms are often bland with all white or all beige tiles, floors, fixtures, etc. It can make very difficult time for an older adult to navigate such an area. Some facilities have opted for black toilet seats in response to resident falls to help them easily distinguish the toilet from other features and better judge where to sit. Remember, with lighting, older people need 2 to 3 times more light than younger people. It's also important to put direct light on a task versus ambient lighting. Let's now consider vision problems that should be reported, which include the sudden occurrence of pain in the eye, flashes of light or bright floating spots, hazy, blurred or double vision, seeing covering coming down over one eye, seeing floating or spider webs, seeing rainbows or halos around lights, unusual or painful sensitivity to light or glare, swollen red eyes, itching, burning, heavy discharge in the eyes, changes in the color of the iris, and white areas in the pupil of the eye. We will now change our focus to the ears and hearing. Some common ear problems you may encounter include infections, noises in the ear such as ringing, clicking, humming, roaring, hissing, buzzing, known as tinnitus. It can be caused by prolonged exposure to excessive noise, infection, earwax, middle ear problems, ototoxic meds. Meniere's disease, which is related to fluid problems in the inner ear, can contribute to tinnitus, but it is also a serious safety issue due to vertigo that is experienced. Presbycusis, which is highly prevalent in older adults, involves sensory neural damage. It can cause difficulty hearing high-pitched sounds like F, S, SH kind of sounds. With conductive hearing loss, there is a problem with the passage of sound through the ear structures. This can be related to ear infection, a hole in the eardrum, or otosclerosis, abnormal bone growth which affects movement of the ear bones. Observe the capacity to hear during your first contact with the resident. Hearing problems can be detected by the resident having a tendency to cock the head to one side, ignoring questions and comments or asking to have things repeated, or relying on lip reading and visual cues. Ask the resident if a hearing aid is or ever has been used. If a hearing aid is used, instruct the resident to use it during the assessment. The best approach to test the resident's ability to hear a watch ticking is to have them close their eyes and then place the watch to the ear and ask them what they hear, if anything. Without the eyes closed, the resident's aware of when the watch is placed over the ear and may give a false affirmative that he or she can hear when he really can't. You can also stand behind the resident or turn your back on the resident and ask a question to determine hearing ability. If the resident uses a hearing aid, examine it for the condition, cleanliness, and function. Questions related to the hearing aid that you'd want to ask include, how long have you used the hearing aid? Where did you obtain the hearing aid? Who prescribed it? How do you care for the hearing aid? What problems do you have using it? Are you able to hear speech and environmental sounds clearly with the aid? If the resident has a hearing aid but won't wear it, it's important to find out why, as perhaps that problem could be rectified. If a hearing deficit is noted, determine the date of the last audiometric examination. If there was none in the past year, obtain orders for an audiometric exam. Inspect the resident's ears with an otoscope for cerumen accumulation and foreign matter. With age, the keratin in the cerumen is of a harder consistency and can easily form an impaction. As a society, the aging process is often the brunt of jokes, and in particular, we laugh at miscommunications due to hearing loss. Hearing loss, however, has a profound effect on the quality of life. It can significantly interfere with activities one enjoys and can cause problems with socialization and relationships. People often treat those that are hard of hearing as if they're stupid or not worth the time or effort needed to communicate. These things can contribute to the development or worsening of social isolation and depression. Try to find out what the resident needs from you for better communication. When someone has a hearing deficit, allow extra time. Eliminate background noise. Face the person directly. Avoid being in a shadow. Speak clearly and distinctly. Keep hands away from your face. Pay attention to nonverbal cues that show confusion, such as a puzzled look. Have them repeat back specifics. Write down pertinent information to assure it's received by the person. Hearing-related problems that you would want to report include increased difficulty hearing, pain in the ear, new onset of tinnitus, new onset of vertigo, and cerumen impaction. Pain is also a sensory experience, so it's important that we include it with our discussion of sensory input. Hopefully, we are not like this poster that minimalizes the resident's pain. The World Health Organization defines pain as whatever the patient says it is, so we need to recognize it for what it is. Pain is pain. Someone can have both acute and chronic pain at the same time due to more than one type of pain-related condition. Acute pain is sudden, usually the result of a clearly defined cause, such as an injury or illness. Chronic pain lasts for weeks or months or more and is usually associated with an underlying condition, such as arthritis. The literature clearly reflects that most older people admit to having pain, and that it's not surprising given the number of pain-related conditions that are often experienced by older people. Pain is a subjective experience, and no two people experience it the same way. This often has to do with differences in pain threshold and tolerance. Pain threshold is the lowest intensity of stimulation at which pain is experienced. Pain tolerance is maximal level of pain that someone is able to tolerate before doing something for relief. Since pain is a subjective experience, it's important to gather as much information from the resident about the pain as possible. Usually, in the nursing documentation, the only pain information is location and pain score. This is not a complete assessment. For the location, be specific. For example, resident complains of leg pain, Tylenol given and effective. Be specific where in the leg. Pain in the calf of the leg may be cause for more concern than pain related to chronic arthritic condition. What words does the resident use to describe the pain? This could give clues as to the underlying condition or cause of the pain and may make a difference in how it's treated. For example, nerve pain is often associated with burning and is usually best treated with a different kind of medicine than other types of pain. Even though pain is a subjective experience, we can quantify that experience by assigning a number from a scale. This allows us to measure pain to determine how bad it is and whether it gets better or worse. It's important that all staff use a similar scale for measuring pain. For example, one chart identified the resident's pain as 5, but described the person as in distress, crying out and moaning. That suggests that the nurse was using a 5-5 scale. However, everyone else was using the 10 scale, which makes a huge difference. If the resident reports a 3, it would be good to know if the nurse meant 3 out of 5 or 3 out of 10. If the person is nonverbal, you can use the FACES scale by matching the person's facial expression to the corresponding face on the scale. There have been nursing notes that say, "Resident continues to be restless and agitated. No signs or symptoms of pain." This only reflects that the nurses are missing nonverbal cues, as restlessness and agitation are signs of pain. Physical aggression during care can also result from pain. The GNA can be moving the resident with utmost care, but that movement may cause pain, particularly if the resident has an arthritic condition. This can trigger behavioral problems and often occurs in those with dementia. Those with dementia have all the same pain-related conditions that other older adults have, but research has shown that they get less pain medication. If they can't ask for it, they don't receive it. There is some research that suggests that there is better behavioral management with analgesics versus psychoactive drugs, so we have to always consider pain as a source. It is important to include more than just pharmacologic interventions to promote comfort. Other physical measures can prove useful as well, such as heat or cold application, massage, diversion, and meditation. Follow up to determine if the interventions are effective. What level of discomfort is acceptable to the resident? Consider threshold intolerance. Some people are okay living with level 3 or 4 pain. Others want to get to 0. Be sure to report new pain, unexpected, or worsened pain. The location and characteristics of pain are important to note, as well as any accompanying signs and symptoms. As you recall from the overview of assessment program in this series, we stress the importance of assessment as the foundation of the nursing process. Once you have collected your assessment data, it's important to analyze that data in order to identify the nursing diagnoses and formulate the problem statement. The nursing diagnosis alone is not a complete problem statement. The problem statement starts with the nursing diagnosis and then identifies what is contributing to the problem. This is the related to portion, followed by how the problem is noted in the resident. That portion is stated as evidenced by. Using your assessment information in the problem statement assures that the problem statement specifically reflects what's going on with the resident and makes care planning much easier, as interventions can be identified to target the specific factors that are causing the resident to have the problem. Some of the potential nursing diagnoses are shown on this slide, along with examples of what a problem statement looks like. This concludes the program. If you have any questions, please discuss them with your staff development instructor or charge nurse. Thank you.